An interesting situation of a canine transposition with a remaining primary canine that calls for treatment. The first idea was to take the canine back into its correct position, but obviously the amount of bone that's present and the proximity of the roots may not be the best alternative. On top of this, the central incisor is very dilacerated and hidden. The apex is hidden behind the canine, which means that we cannot derotate this tooth without resorbing the root or resorbing the canine. So the idea was to extract the primary canine, translate the lateral incisor into the canine position, torque and move the canine out of the way of the apex of the central incisor, do an epicoectomy of the central incisor, and place porcelain veneers or composites on the canines and lateral incisors. This is the case at the beginning of treatment with the transposed canine. The primary canine still present. The rest of the malocclusion is pretty non-eventful in the rotation of the tooth. If you take a Panorex and a Ceph, you don't really see you can see the significant dilaceration. So we retracted the lateral incisor using a power arm and a lingual TP bar and a segmented wire on the buccal side, and we managed to translate this lateral incisor without damaging the roots. Now it's time to get the torque of the canine to be correct. So now we have a cantilever that is putting a buccal force and some distal root torque to the canine within reason, as we are limited in the amount of movements we can do. We now have the second cone beam prior to the endodontic surgery. We will also fuse the IOS in order for us to create a guide for the endodontist. As you know, it's very hard for him to determine where is the root of the tooth or the apex of the tooth. So this is where we are right here, and now we can see that we have an access compared to the first cone beam that we had at the beginning of treatment. The lateral incisor is in good position, but it's very complicated. As you see, the roots are very close together and dilacerated, so it will require indirect bracketing to make sure that we position the teeth where they're supposed to be. 7 months or 8 months of treatment, this is now the situation. We've been able to distalize the lateral incisor in its correct position. We also are starting to torque and get the canine into a better position, but the problem is that we have a bit of a buccal perforation of the root, so we decided to kind of stop at the moment, look at the position of the lateral incisor. The endodontist feels that now he's able to cut this root if we give him a good approach, and it's called a plane cut. I will demonstrate with this software what is the plan for the endodontic treatment. This is roughly what will be achieved by the endodontist. We're still working with him on the creation of a template that will be 3D printed. Roughly this is the amount of root that will be removed to accommodate the rotation and the positioning of the canine. I show you this piece of root, but now let's see what will be left of the tooth and accept. This is the root that will be amputated, the part of its apex, and we can also smooth the whole root a little bit, and this is what the new tooth would look like. This is the result we're aiming for. What we've done is reposition the canine in the lateral position, amputate the root, put the lateral incisor in the canine position. We also added a veneer on the lateral incisor to make it like a canine, and we've done the same for the canine, reduced it and made a composite or veneer. So this is the plan, where we can now decide to rebracket these teeth to get the best possible outcome of the position of these teeth. So basically that's the idea. You can see now that the roots are very still close here, but they've been correctly positioned. The root is amputated as shown before. It's hard to see with the maxilla, but it's still there. There's still enough root for the tooth to function. The root is about here, and the occlusion is pretty acceptable.